Hello, my name's Alex Turner and I'm a consultant paediatric urologist practicing in Leeds in the UK. My special interests are genital reconstruction, kidney and bladder surgery. I trained in Leeds, but I'm originally from Manchester. Hypospadias is a congenital abnormality of the penis. That means that a baby boy is born with it, and it's usually noticed straight after birth. The issue is that the water pipe doesn't open up at the end of the penis in the glans, as it should do, and it may open up on the front of the penis, anywhere from the glans all the way down to between the scrotum in more severe cases. It's also associated with a bend of the penis, which we call chordee. Also, the foreskin will be bunched up around the back of the head of the penis. We call that foreskin hooding, and this is another feature of hypospadias. Babies with hypospadias will be able to wee normally, although it may come out at an angle which isn't normal. Hypospadias is not life-threatening. And so once it has been diagnosed, it can be safely left until it is reviewed by a paediatric urologist. Once a baby has been diagnosed with hypospadias and has been reviewed by a paediatric urologist, it's really important that the timing of surgery is discussed. The timing of surgery is completely dependent upon the type of hypospadias and how severe it is. Also, how large the penis is, and penile growth occurs throughout a child's life, but particularly at around 1 year old, when a baby boy will have a mini puberty, a testosterone surge, where the penis gets larger. It's really important that operations are delayed until after this time, because the success of an operation is directly related to the size of the glans and the ease with which we can reconstruct the pipe within the glans. Once the paediatric urologist has looked at the penis and decided when the best timing of surgery is, typically that's between 18 and 24 months, the planning stage occurs. In a more mild hypospadias, where the urethra or water pipe emerges towards the end of the penis, this would almost certainly be treated with a single stage operation. This involves correcting the bend of the penis, bringing the urethra into the glans, and also doing something with the foreskin. And people vary with their opinions on this, but the options are either with circumcision or foreskin reconstruction. In the case of a more severe hypospadias, more planning is involved. And sometimes we need to do this operation in 2 stages. The first stage would be to remove the very dysplastic or poorly formed tissue of the water pipe and replace it with a graft. And that typically comes from the foreskin. 6 months after this operation, we then go back and reconstruct the pipe to make the penis whole again. And under these circumstances, the penis will be circumcised. So typically in these more severe cases, the treatment can take up to a year or 18 months. During the operation to reconstruct the tube and straighten the penis, we usually insert a catheter, which runs from the bladder to the outside. This usually stays in for about a week. Once this is removed, then it is possible for some complications to occur. Sometimes the new pipe narrows down. This is called meatal stenosis. That can also put some pressure on the original pipe, the original hole where it emerged, causing it to become a blowhole, or what we call a fistula. Also, if there is infection, then sometimes the wound breaks down completely. General risks of any operation are also possible, such as infection and bleeding. The risks are low, but increase with the severity of the hypospadias. Typically, for a mild hypospadias, the risks of all those would be around 5%. But with a more major reconstruction, the chances of having a complication can rise to 15 to 20% or beyond that. Long term, the penis should be well reconstructed, it should be straight, the child should be able to urinate in a straight fashion, and so there should be no long-term problems. But as with all the complications, sometimes reoperation is necessary. Babies are extremely resilient, much more so than adults. And when we do this operation, they're still, of course, very young. They wouldn't remember the operation. It's before they go off to school. And so they recover really well. The first week after surgery, they're given an antibiotic and also a medicine to relax the bladder because the catheter is inside the bladder, because sometimes they can get bladder spasms. But most children tolerate this really well. The catheter is in place for around a week, and once that comes out, then that discomfort should go away completely and they should be back to normal. From their general health point of view, if children are fed and watered, just some simple pain relief is enough. It will be discussed with you at the time of the operation about what sort of pain relief is appropriate. Usually some sort of anaesthetic given, like a caudal anaesthetic, into the back will numb the whole area for about 8 hours after the operation. Simple analgesia such as paracetamol or ibuprofen can be given, and sometimes Oromorph is given, which is an opioid, and that can be used for a short time afterwards if there is some distress. But generally speaking, the children recover and do really well. As the child grows older, the penis will grow in the normal way. Sometimes there are some cosmetic elements to it that need addressing, such as loose skin or tight skin. And sometimes they need further operations to tidy this up. As I said before, with complications, sometimes if the hole gets tight, that needs further surgery as well. And that can happen quite late after the operation is originally performed. And so for that reason, we keep an eye on boys with hypospadias and do checks such as a uroflow test to make sure that they're weeing in a strong straight stream. Later on, with a foreskin reconstruction, occasionally it can become a bit tight, as all foreskins can. Sometimes this can be treated with a steroid ointment. Sometimes a circumcision is necessary later on, but this is rare, as the foreskin should be retractile at the end of the original operation. Later on, as they enter puberty, the boys should have a well reconstructed penis, which they're happy with cosmetically, and they should have the confidence to go about their lives as normal.